Thank you very much, and thank you very much for inviting us here today, Beckers. Hello, everyone. My name is Chris Mancy. I'm the CEO and co-founder of Viz AI. It's great to see everyone here today. We've got a great panel for you of leading clinical, hospital administrative, and AI and radiology experts. By quick introduction, we have Dr. Jay Mocco, cerebral vascular and endovascular neurosurgeon at Mount Sinai, who's also the president of SNIS. Dr. Mocco is actually currently in an emergency operation that was rather complex. And so his partner, Dr. Christopher Kellner, who's also a cerebral vascular and endovascular neurosurgeon at Mount Sinai, will be joining us as well. We also have Andy Draper, PhD, who's the CIO of HCA Continental Division and the founder of greencio.org. Andy has tremendous experience in both assessing and scaling artificial intelligence solutions across a large network across the United States. And finally, we have Dr. Susie Bash, the medical director of neuroradiology at San Fernando Valley, an interventional radiologist at RadNet, with a tremendous amount of experience of using diagnostic AI across a variety of diseases. And before we jump into the panel, I want to give you a quick overview of Viz and what we do here today for our health systems. By way of background, I'm a neurosurgeon and I co-founded the company out of Stanford in 2016. We were the first company to receive an AI indication from the FDA, creating the de novo pathway called computer-aided triage. And we have 8 FDA-cleared algorithms, all of which have CE marks as well for Europe, across a variety of diseases in the cardiovascular, neurovascular, and vascular domains. And we were also the first company to ever receive a new technology add-on payment for artificial intelligence back in 2020, which really opened the door to reimbursement for artificial intelligence across a variety of different disease states. And we've really created what was known as healthcare system of action, which, in contrast to the EHRs, what you might think of as the system of record, is a system that triggers action using AI to find the right patients and get them to the right place as quickly as possible. Today, we're in over 1,200 hospitals, covering over 200 million lives, and with over 400 employees across the globe. We are in a variety of health systems, and I know many of you have joined us here today, so thank you. And we've really learned from our systems, the large integrated network, the academic hospitals and the hospital systems, because technology on its own is of no use. It's really the application of that technology into the clinical workflow that allows us to help our patients and improve patient outcomes. This is what the system of action is. It's a simple concept, but one that's actually very powerful and that is revolutionizing healthcare today. Essentially, what we do is we ingest clinical data, whether that's a scan of a patient's brain, an ECG, or clinical report. We apply artificial intelligence analysis to that image or report to automatically detect particular disease, to measure the size of disease, or predict what might happen next with that patient. What that does is it makes that healthcare data meaningful and allows us to trigger action, whether it's alerting the appropriate specialist or potentially it's the research team about a clinical trial patient, allowing them to easily take the next best clinical action. And this has meaningful results. It allows the patient to get the right care at the right time. And essentially what this does, it means you get better patient outcomes because they're getting the right treatment in a timely manner. You're getting a higher treatment rate for particular diseases, and you're also getting a big improvement in provider experience. Today, we're announcing our Viz Enterprise platform. This is one platform across unlimited clinical applications. What we have done is we've added the ability to support third-party applications to the Viz AI platform, so our hospital systems can benefit from an unlimited number of AI algorithms that either we develop in-house or our third-party partners will develop across numerous diseases: neurology, vascular, cardiology, radiology, chest, spine and ortho, and oncology. Really, you name it. If there's going to be patient benefit, if there's going to be operational financial benefit for the health system, that's an algorithm that we can support. And we have support for all of these modalities: CT, MRI, X-ray, ultrasound, ECG, echo, and angiogram, and numerous integrations. But really, this is all about the care teams. If you just help the radiologist like Dr. Bash or the neurosurgeons like Dr. Kellner, you're not helping the patient fully. You need to ensure that there's good care coordination triggered by the AI to allow them to do the job that only they can do and that they know best. The enterprise platform has three key functionality areas. First of all, an image viewer that allows the display of any image across a mobile and desktop platform, full PACS and worklist integration to allow the radiologist to prioritize cases that have been flagged by the AI that might be of concern, and also this third-party AI allowing any AI algorithm to integrate with Viz. And we'll be announcing more of those partnerships at RSNA. The goal is to develop intelligent care pathways that detect more patients, that allow the doctors to diagnose those patients faster and in real time, that propel clinical action by getting the right specialists together with the right care teams to allow the patients to move through that workflow faster, to drive increased disease awareness and increased awareness of therapies that might treat that disease. If there's a patient with a rare cardiology disease, we need to get them to the cardiologist who specializes in that disease so that they can diagnose and provide the right therapy. So essentially, it's about connecting the right patient to the right provider at the right time, facilitating communication, and driving real-time action. The results speak for themselves. This is a case study of stroke, which was our first indication, ischemic stroke. In ischemic strokes, when a blood vessel in the brain is blocked and the brain gets starved of oxygen. There's very good treatments for it if you get these patients to clinicians like Dr. Kellner on time. They can go in and remove the clot, reestablishing blood flow and allowing that oxygen to get to the brain. If you do that quickly, you see a big improvement in patient outcome. And what we see when we implement Viz is significant improvement in outcomes, significant improvement in provider productivity, that's minutes saved and uses of things like the angio suite room, significant improvement in resource allocation, particularly reduction in the neuro ICU, as well as decreased overall hospital length of stay, and also more patients getting the procedures and the treatments that they need. And so I'm very proud of what Viz has done in really not just AI, but applied AI to healthcare in a really clinically focused, workflow-focused way. So today we brought together real experts, clinical experts, radiology experts, and administrative experts to really talk to us about how leading health systems are streamlining their care with AI today. And so, Andy, I'd love to open it up to you. What are the biggest challenges you are facing today in your organization?
Well, good afternoon, Chris. Thanks for having me. All the industry right now is suffering from shortage of staffing. Bottom line, we are having physicians retire early. We have nurses retiring early, and there's no real change in that in the next few years as people predicted. So what does that mean in the day-to-day? What it means is people want to know, what do I need to do now? And so I've often said, the picture paints 1,000 words, and Viz makes it disseminated across 17, 20 different people. So when the scan hits CT and it starts to go through, the image is sent to the phone, through the Viz processing application, and then through the clinical communications tool, 17 different people can have it. The physicians, the ED doc who's referring the patient, the radiologist, transfer center, everybody who's involved in that care team. And that really helps them in a tight staffing model get to the essential critical care that needs to be done at that moment. And that's been a big win.
That's fantastic. Thank you. And Chris and Susie, any comments on what the biggest challenges you're facing in your organizations?
Sure, I could start. I would say from the radiologist perspective, one of the big things is just physician burnout. We feel like we're always, looking for excellent radiologists to join. We're, always in need of more help, it seems like, increasing workloads all the time. So that's a source of frustration for radiologists. I would say from an administrative perspective, just to give you a little background, the company I work for, RadNet, they're sort of the largest freestanding outpatient imaging enterprise in the U.S. So we do about 8 million exams a year. So we have around 750 radiologists, 350 sites. So it's a large organization. And I would say the primary challenges from the administrative point of view would be the impending Medicare cutbacks and difficulty retaining knowledgeable technologists. And then also that continual focus on workflow efficiency. And, there's certain things you can do, you can take action about. There's other things that are a little bit more out of our control. I can tell you for things like trying to, the problem with retaining knowledgeable technologists, we use a remote operation command center, or ROC, which basically allows a knowledgeable tech lead to sort of, remotely log into the scanners throughout the country and help guide, if maybe someone is not quite sure of the correct protocol, or et cetera. And then in terms of workflow efficiency, and we can talk a little bit about more about this later, but we use something called deep learning for image reconstruction, and allows us to scan our patients between 40 and 70% faster, but at higher image quality. But that's sort of the summary of probably our main challenges.
Chris?
Yeah, everybody, Chris Kellner from Mount Sinai. To kind of combine those two answers, physician burnout and healthcare worker burnout is a major issue. And then also interfacing with the electronic medical record and the PACS system. Those are major challenges to get the administrative burden done, and that definitely contributes to burnout overall. Figuring out a way to streamline getting data into and getting data out of the EMR in a better way is, I think, one of the major challenges.
Fantastic, thank you. And Chris, next question is to you. What clinical impact have you seen at Mount Sinai or in the general AI space from technologies like Viz?
Yeah, the impact we've seen from Viz has been quite significant. We adopted Viz in 2016 or 17, pretty early on, I think. We saw a dramatic increase decrease rather, in the amount of time that it took us to get notified. And we actually published that, where we were notified 15 minutes faster in the post-Viz era than in the pre-Viz era, which when you're dealing with an acute ischemic stroke, that 15 minutes really does matter in the patient's outcome. We also saw, other than just that time effect, improved care coordination, because suddenly you've got everybody getting the information at the same time. So rather than a serial link of information, you've got this information disseminating, and everyone can then spring to action. So not only the notification, but the care coordination has been a dramatic change for the way that we interact during an acute neuroemergency. We have to call in maybe 5 different people just to do that one procedure, with the neurologist and the ER doctor communicating with the neurosurgeon, but also a nurse, a radiologist, a technician. You've got a lot of people interfacing, and to have that suddenly occur simultaneously really is a big impact, other than just the time to notification, which is the number everyone talks about. But then really the ease of access to radiology imaging. Previously, we had to get to a computer where we had an internet connection and then sign into PACS to review some imaging. I used to actually bring my laptop to dinner with my wife on dates when I was in the pre-Viz era, but because I might have to sign into PACS to review some imaging. But now you can review it in a high-quality PACS viewer that's mobile. And that was really, just from my personal life, a big, significant change. Then you've got system coordination. We have a large healthcare system in New York City. We perform thrombectomy at 6 centers, and we're bringing on a 7th center. When we wanted to bring on that 7th center to perform thrombectomy there, they already had Viz. So instead of everyone getting the login information and accreditations for that hospital to make sure that they can get their own PACS logins and then figure out how to get remote access to VPN, we just turn on a switch and suddenly we all have Viz, and we can triage, really immediately without any administrative burden there. So There's improved system coordination with Viz. And then finally, other than just ischemic stroke, there's also the possibility of getting notifications to people for elective findings, such as an unruptured aneurysm and other findings that are in the other disease processes you mentioned, where it decreases the chance of that Swiss cheese effect, where if the one person who ordered the test doesn't see that result, now you've got the specialist also seeing it, you've got the patient also seeing it. So getting that information out as quickly as possible to multiple people limits the chance of there being an issue and just decreases the overall time to action for that. So it really has been quite a significant change since we adopted this.
Thank you. So early notification benefits the patient outcome, the care coordination across multiple different teams and specialties, system coordination, and then I love how you put that, the Swiss cheese effect, find more patients who may have dropped through the cracks, like unruptured aneurysms. But if those patients aren't found, an unruptured aneurysm can very easily turn into a ruptured aneurysm.
Yeah, exactly.
Yeah. And Susie, what have you seen from the radiology world?
Yeah, so we use a lot of different AI applications at RadNet. They're a pretty forward-thinking company. I don't know how many, but let's say maybe 10 different AI solutions that we use. We either incorporate an AI company or we partner with them. And so we've been using it for a long time. I've actually been using AI in my clinical practice for about 15 years now. And, really all of the AI tools that we use have, positive clinical impact. But I would say, if I was going to say the most important or most profound clinical impact, I think in the market space, in the AI market space, I would put triage apps as number one, and cancer screening AI tools also up there as well. In terms of triage apps, as Chris was mentioning, being able to detect and diagnose critical findings on imaging, particularly like LVOs. Obviously, when a patient has a stroke, they're losing 1.9 million neurons per minute when they have loss of blood flow. So, timing is absolutely crucial. And, again, the Viz LVO software will detect that LVO before even the radiologist sees it and alert it to the entire multidisciplinary team. And really that time saved from the door, the time they enter the door until the time of thrombectomy is about 1.5 hours. So it is significant, obviously resulting in significant impact in clinical outcome, 45% cognitive improvement and decreased length of stay in the hospital. I think it's 3.5 days for neuro ICU stay and 2.5 days for general hospital stay. And that's, doesn't only translate to a lot of cost saving, but really also, other complications that can happen with longer stays, like nosocomial infections, which are not uncommon in the hospital. But also these other critical or urgent, or not always urgent, but critical findings, things like aneurysms or intracranial bleeds, subdural hematomas, pulmonary embolism, aortic dissection. These are all very, very important features that cannot be missed in radiology. And I remember still, I've been a neuroradiologist for half my life now, but I still remember, first year residency at UCLA in the ER reading room. And, if someone comes in with the worst headache of their life and they do the CTA, and I'm, scanning and I'm sweating, trying to make sure, what's an infundibulum versus an aneurysm, what might be venous overlap. And to have an AI tool there, kind of like an attending on your shoulder when you're all alone, is a very, very important and critical thing for, radiologists that are starting out in their career, and also for the rest of us as well. For when it comes to intracranial bleeding, the largest volume of bleeding typically happens in the first 1 to 2 hours. And really, the earlier that diagnosis is made and the care team is notified, the better the patient will do. So triage apps, I think, are extremely important and can save lives. Cancer screening AI tools also. At my company, we use a cancer screening tool called Deep Health. It actually will detect breast cancer on mammograms 1 to 2 years before expert breast radiologists, which is absolutely incredible. Doesn't matter how you feed the AI, algorithm. The AI algorithm always beats the humans every single time. So we've implemented that throughout our imaging enterprise already. We also have other AI tools that are in development for cancer screening for lung cancer and prostate cancer as well. So I think that any kind of AI solution that can help save lives is going to have the biggest impact.
Thank you. And so triage tools, cancer screening, and supporting education and training, all very, very massive improvements that we need across the board. We've got a question that came in from the audience, which ties in actually to my next question around collaboration. The question is, when you have a simultaneous notification to different healthcare providers, how have you managed the too many cooks problem? Now that multiple people are notified, how are their actions and decisions coordinated? Dr. Kellner, I'll ask you that.
That's a great question. It's a good problem to have, that too many people know that there's something going on that needs to be addressed. We already had a hierarchy in place for who's coordinating primarily. And so that still is in place with the use of Viz. And, there's a neurointerventional fellow and there's a neurology fellow. And from both sides, the medical side that's going to care for that patient and the surgical side that's going to care for that patient, they're communicating and making the decisions about where the patient's going to go and who's going to go there and making sure everyone's on board. So we do stick to the same hierarchy that we had in the pre-Viz era. It's just kind of augmented, and everyone can see everything happening.
Dr. Bash, how about from radiology collaborating with the entire care team? You've got a whole list of patients that you're reading the images of. How has AI allowed you to better coordinate with those other specialists?
Well, I would say using an AI tool, clearly this is beneficial, when we're talking about in the hospital setting, but even in the outpatient setting, I think there is a great need for streamlined communication. I think there's not a single radiologist in the world that hasn't felt the frustration and challenges when they see a critical finding on imaging, and particularly when it happens in the middle of the night and you're calling, you cannot get to the referrer, and sometimes the patient needs to go straight from the scanner to the nearest hospital if it's an outpatient, even if they're in the outpatient setting, if there's a lot of mass effect on the brain or things like that. And so, really having a good communication tool is something that all radiologists would love. And the truth is, calling, picking up the phone and calling just, will often take you through, just sort of the forest, and you can't actually get to where you need. But everyone has their cell phones on them, and having a cell phone app with a HIPAA secured means of communicating, I think, is really the most logical approach. And so I think that's one of the greatest strengths of the Viz software, is that multidisciplinary alert system.
Yeah, I think that's one of the keys that I'd add, right? It's not just the AI, it's the care coordination and communication. We have a study coming out at the Society of Vascular Interventional Neurology this month, looking at our aneurysm tool. And what we found was that it finds a tremendous number more aneurysms, not necessarily that the radiologist hadn't picked up, but they were under the neurovascular team. And so somewhere along the line, the workflow is breaking down, whether it's at the PCP or there's the difficulty of getting hold of the right care team, or maybe it's the on-call care team who doesn't pass it on. It's very varied where it broke down, but getting that information to the right clinician ensures that the right care pathway will be followed. So I agree with what you both said. Andy, open up to you. You are the CIO of a very large health system. How have you seen care coordination triggered by AI benefit your processes and your clinical processes?
Well, first of all, the docs are happy. All the physicians that have been mentioned here today in the different roles, our nurses are happy because they know where to focus. The ED's happy. The neurorads across the country are happy. The stroke coordinators are happy. And I think to the point about, is there too many cooks? I think the opposite is proven true in some cases, where the more people that have the information in a timely way, the faster decisions are made. So the coordination between the life flight, the ED, the referring ED from our rural hospitals to the stroke center, all those messages and communications can happen in a second. And then, of course, you build a wonderful app where you can do a phone call. And I've just gone out to the web, and I know that the Viz training app is available, and I just downloaded it, and you can see it. And it's very easy to demonstrate and communicate. So as a CIO, one of the things I am sensitive to is, will it work, and will these high-value physicians yell at me? And the answer is no. And they found it to be useful, immediately deployable, and everyone involved in that care team and your other services that you're expanding to, Chris, have been very happy as well.
Thank you. And you know, building on that, Andy, your system, your division of HCA Swedish in Denver was one of the early adopters and really tested Viz out in the early days, just like Dr. Kellner did at Mount Sinai. So you've known about AI and how to implement it from really early in our journey as a company. How do you think about assessing AI algorithms and AI vendors, implementing them, and scaling the deployment of artificial intelligence?
Well, that's a great question. First of all, as a CIO, I was early in the discussions with Viz and trying to understand, will it have the potential to become a platform? And I'm thrilled, Chris, with your announcement today about the enterprise platform. I did not know that. But it helps me as a CIO to not have the alternative of a common platform that does AI off the CT scan, because one of the real values with Viz is it's connected to my CT scanners, is that it is, I don't need body part apps. My fear in the beginning was every body part, every organ, every subspecialist was going to come to me and say, hey, I need my GI app, I need my pulmonary embolism app. And I was hoping that we could find an imaging AI algorithm and the ability to communicate in one solution. And I think that's absolutely been proven true with Viz. We're doing pulmonary embolism. The clinical communication tool is important for referrals and closing that communication. To answer your question briefly, and then I'll end, we have over 70 hospitals in our network. We have freestanding EDs, we have emergency departments, we have rural hospitals that are connected as well. And it was very important to be able to say, not only do we want it for the big house, but for all the other neighborhood houses in our network, which I think are about 70 plus hospitals now. And so the ability to have a platform that would scale to that and connect to the cloud and get the images back to the physician within 6 minutes or less is super powerful, and it worked very well.
Yeah, well, actually, that reminds me, one of the interesting things that you did was you not only put it into in-network facilities, but you also went out and offered it to your connected out-of-network facilities. How was that process for any other CIOs or administrators who are thinking about doing the same?
Well, from a legal perspective and from an ethical perspective, our clinical team said we want to leave people in the rural communities, and we're in Denver, and so we've got outlook places across the great mountain area, Wyoming, Nebraska, Kansas. If they can remain clinically in their local rural hospital, if it is not a stroke or a pulmonary embolism or something that can be treated locally, it is part of our mission to do that. It's part of our rural outreach mission. So in the cases where the care team is activated with Viz, they look at the analysis on the images and the AI and the clinical communication tools, and they can say, no, it's just a really bad migraine. Please keep grandma in the local community. That's a big win. And that is important to the rural docs and also and to our rural mission. So it was a very successful communication strategy as we went out there to the rural hospitals, said we want to use this tool. It's cutting edge. You're getting the best caregivers with the best artificial intelligence algorithms in the world, and it'll help you keep your patients local. And that was a very powerful message.
Yeah, and I'll add that I think what works is when the platform provider, that in this case it was Viz, collaborates very closely with the clinical and administrative teams of a hospital system to scale in the way that makes sense. And we've seen tremendous success. Not only those 70 local hospitals, we're now in I think over 12 divisions across the HCA network. And for those of you in large health systems, that kind of pilot in one system and expand seems to be a very good model to follow. And Andy, commend you for kind of being the first one that I've seen to do that really, really well. There's a question that's come in from the audience, which is very relevant, which is how do you balance the number of independent AI solutions available with IT resources that we all know are now very, very short-staffed? And how do you both manage the balancing the deployment, but also the management of these different applications?
I could maybe comment on that. There are so many different AI tools out there on the market space, and it's very hard to know which ones to use, which ones are, all these vendors have high value claims, but how do you know which ones will actually work in your enterprise? And so I think it's very important before choosing which AI solutions to really assess your practice needs and then research which AI solution will fill that need. And obviously, the broader the AI solution, or, as you said, having sort of an enterprise platform like what Viz is offering, the more applicable it may be to your practice. And then I think it's also important to evaluate, make sure that there have been clinical validation trials that show that AI solution works in the real space, not just where they train the algorithm. And so, multi-center, multi-reader blinded trials, I think, are very useful in showing that, that the AI solution does what it says, what the vendor claims it will do. And then after that, sort of assess the ROI for your enterprise. And then in terms of actually implementing, we found that, like what I can give you an example for like deep learning for image reconstruction. What we did was pilot studies where we had regional section leads would assess the images, both the standard of care side by side with the deep learning enhanced image. And then the radiologist, the section lead, whether MSK or neuro, would look and they would see, okay, I can clearly see this as improved image quality, but yet we were able to do it, 70% faster. This is a go. And then once they become excited about it, they can get the rest of their section excited. And so through those pilot studies, you can basically get everyone on board when it's a very large enterprise. So that's one strategy that we have taken. But as you say, I think no one wants to just pick and choose numerous different things. It's much better to have a larger toolbox or a platform that can actually work with third parties if need be to grow your AI solution for your enterprise.
Thank you. Andy, how would you, as a CIO, how do you think about the proliferation of, I guess, AI applications or apps that are out there?
Yeah, I looked at Ray on LinkedIn. I think he's the Pennsylvania Ray. Well, first of all, the implementation was very simple. We assigned our imaging manager, Brian Phillips, who was outstanding, to partner with the Viz implementation manager. A lot of the hard work and heavy lifting of Viz is in the cloud. So then we got those connections done from our PACS and DT. We used our router, et cetera, and then got that to Viz. And that was part one. Part two was then getting the app deployed in the physicians and the whole care team's hands. And really, it was very simple. The training, the application's very intuitive. Now, and it was very easy to train on. And I even was showing folks, the Viz training app, which you can download as well. And I would use that during cocktail conversations at the holidays a few years ago. Chris, they were saying, well, what are you working on? I'm like, well, let me show you. So it was very simple to install, and it's intuitive. It's very easy to train. So I think it was a very timely. I think we went from, and we pushed really hard. I pushed the Viz team hard and our team hard. And I want to say we were connected with an application, with the phone app in a physician's hand within 6 weeks.
I think that's right, and I think you speak to a very good point, because there's IT resources, but there's also the training resources, because again, the AI on its own is not going to do the job. It's the training of the nurses, the physicians, making sure that they can log in, like simple things that can cause the whole product as a whole to break down. And so I think in answer to the audience question, it's not just like IT resources. You have to think about all the other resources to deploy. And so our view is that choosing a trusted partner that will be a partner for long term, who's willing to work with anyone else to help them deploy their algorithms in, because no one company is going to build all of the AI. In fact, I will tell you that some of the AI that I'm most excited about is being built by clinicians who are clinician scientists who've spun up their own AWS server, S3 bucket, and are building their own deep learning algorithms for a clinical problem that they're already an expert in. And so, a platform like ours will be happy to support anyone in deploying those, not just through IT, but through all of the different parts of the workflow that's needed. Fantastic. We talk about the enterprise AI, and happy to announce that today. How do you think about AI's application beyond your own service line, beyond radiology, but beyond neurosurgery? Is this something that you think can expand broadly and become the standard of care for multiple diseases? Maybe open that up to Dr. Kalner.
I feel like we got a little bit of a head start by having Viz work and develop large vessel occlusion triage first and CT perfusion processing. I don't really know what the other offerings are, being a neurosurgeon and focusing on this, but it is exciting to see that other fields are also benefiting. It seems like initially the real need is in rapidly triaging emergencies. And then after that's covered and the emergencies are figured out, then you have the opportunity to develop algorithms to identify non-urgent findings and care coordinate around that. And that's happening as well, and that's very exciting to see. And my specialty is benefiting from that with the unruptured aneurysm finding algorithm. And then I see there being some additional recommendations from your algorithm. For example, when you see an unruptured aneurysm, there are lots of features about that aneurysm that come into play. The size of the aneurysm, exactly the location. And these are things that your software can eventually automatically determine. And then because we have those features, you can then provide some data-based information to the provider. Hey, this aneurysm in this location has a rupture risk of 2% per year or something like that. So I see that being the next step down the road, where you've got some, not necessarily recommendations, but some additional information, like a clinical heads-up display for you to help guide your information and decision-making with a patient.
Yeah, I'd agree with that. I think right now AI is triage, detecting disease and getting to the right place. Population health or screening, like Dr. Bash mentioned, for things like cancer or maybe rare cardiac disease or unruptured aneurysms that were missed. And measurement, volumetric measurement. But I think the future really is going to be in predictive algorithms. Once we have enough data to know what happened to that patient, did they have treatment A or treatment B, and what was the outcomes, I think we'll be able to start using AI to better guide our treatment protocols and help more devices be developed and more drugs be developed that will treat more patients better.
Absolutely. And also once we can show clinical benefit of AI tools to CMS, hopefully get some better CPT codes for some of the AI tools, and again, the new technology add-on payments, because the ROI is a big issue. All imaging centers are businesses as well. And so, and it's a very interesting question about standard of care because, first of all, on a broader spectrum, I think any area of our lives that are impacted by technology will soon be transformed by AI. Doesn't matter what field you're in. So subspecialties within healthcare that are more tech-oriented, like radiology, are going to be impacted by AI tools they'll be implemented at a quicker pace than other non-technology oriented subspecialties. But in terms of what becomes standard of care, for example, of the 10 or so AI tools that we use at RadNet, I think that all of them will become standard of care, but not all at the same time. There's very low-hanging fruit, like things like deep learning for image reconstruction. The patient wants to get in and out of the scanner faster, so it's a win for them. It's a win for the radiologist, better image quality. It's a win for the imaging enterprise. They can scan 50% more patients per day. The ROI is high, probably at least 8 times, the ROI. So that's very low-hanging fruit. In fact, the initial company that did this, which is vendor neutral, all the OEMs then copied it. Now every single OEM is coming out with a deep learning for image reconstruction, and at different levels of fruition with FDA approval. But that will 100% become standard of care. Triage apps will 100% become standard of care. I believe in the future, again, there's not going to be a single radiology image that's not first analyzed by a computer before a human reads it. It doesn't mean that I think AI will take radiologists' jobs. I mean, the truth is that AI is better at pattern recognition, but humans are better at global reasoning. So they really go hand in hand. You really need both. Cancer screening tools, the AI solutions will 100% become standard of care, but they're still in development. Again, we've got a great one so far for breast cancer screening, but lung cancer, prostate cancer, those are all still in development. As Chris mentioned, quantitative volumetrics will be huge. It's very hard for a radiologist's perspective to measure volume accurately due to differences in slice sampling and head angulation. And, the volume is really critical, and radiologists are overworked. And if the patient keeps coming back, like for something like a brain tumor, and they keep imaging every 3 months, everyone's going to say stable, 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 stable. And then you look back a year ago and you see the brain tumor has actually doubled in volume. And so that kind of thing is a very, very easy thing for AI algorithms to do. And like you were talking about with aneurysms, accurately measuring the body and the neck of the aneurysm, so you know whether you're going to do flow diversion or coil, or if they're going to need a clip or something like that. Again, very easy. And also radiologists don't like spending time doing 3-dimensional measurements. They're not as good at it, and they don't like spending the time. So we use quantitative volumetrics primarily right now for in the brain for dementia and for multiple sclerosis, but we also use it for epilepsy, and it's moving into neuro-oncology, and quant is used elsewhere throughout the body as well. And then the less sexy thing, the AI tools that will definitely become standard of care, would be front office things. We currently use AI to improve our billing, the accuracy of our billing. We use it to help prevent no-shows, and we use it to help patients reminders to come in for their annual mammograms. But that front office component will definitely become standard of care as well at some point in the future. And again, these will happen in different stages.
And Dr. Cullen, you're using some of our tools for some of your clinical trials. Dr. Cullen is one of the leading surgeons on the development of treatments for things like brain hemorrhages, where we don't have clinical trials yet demonstrating that the treatment definitively works, but you're working on trials, and they use volumetric analysis. How has that impacted the trial space?
It's really been quite dramatic. I use it for really 2 disease processes: intracerebral hemorrhage identification and then measurement of the volume of the hemorrhage. There's something to be said about adjudication of the volume. You were saying that radiologists don't like doing the measurements. No one really likes doing the measurements. You have to pull up PACS and use the measurement tool. And then you have to do some additional calculations. There's a lot of leeway there, and having the adjudicated volume that everyone sees that, and is that patient eligible or not for that study from that volume, that's extremely helpful. You don't have people arguing, is it over 20 or under 20? Well, I got this and I got that. So having adjudication, there's a lot to be said about that. We have a trial going on called the Membrane Trial, funded by Cerenovus, evaluating MMA embolization for subdurals. And our enrollment in that trial dramatically increased because it's a disease. Subdural hematomas are a disease process that can be seen by a lot of different kinds of doctors. They don't all necessarily go to a cerebrovascular neurosurgeon. And so we were missing a lot of them that we didn't even know about. And then when we activated the research app for triage of this disease process in this trial, we dramatically increased our enrollment rate because we were able to identify a whole bunch of patients we were missing otherwise. So I think those are really the 2 features that make a big difference in managing a clinical trial and maximizing your trial enrollment.
Absolutely. And you brought up a good point about, for things like subdural hematomas, just due to the, concavity of the skull, if you're trying to do it manually, it depends on where you place the measurement. And there is a huge subjective component because one radiologist may measure it in one location, another radiologist may measure it in a different location. And then the referrer is like, well, what is it? Is the subdural bigger or is it smaller? And why are the measurements completely off? Again, quant AI solutions do a really, really good job of that. So I can see why it's being utilized in trials. And in fact, they're using quant even for like the, Alzheimer's trials to measure substructures of the brain that are pertinent and memory loss. The phase 4 clinical trials will all be kind of using the quant. And not only that, but we'll be using it for screening for ARIA and other things like that after, we actually get, reimbursement for a drug, hopefully in the future. But yeah, the AI tools for quant are here to stay and a huge advantage in reducing subjectivity.
Fantastic. And Dr. Bhattacharya, you were talking about the reimbursement and the finances of this and how important that is. We've got a question from the audience here, and I can maybe help answer as well, because I know this space relatively well. How has AI-assisted screening get reimbursed in Canada and the US? Any private insurance or any public healthcare program covered? Or in most cases, do patients pay for themselves?
Okay, is the question particularly related to cancer screening or just screening for any particular disease process?
I think it's probably like generally, how is AI reimbursed today? How may it be reimbursed in the future?
That is one of the biggest challenges to the whole AI market space. And really what Viz was able to do was, I think, one of the biggest things that has ever happened, because it really introduced for the first time that new technology add-on payment, which came from actually demonstrating to CMS that you were making a difference, impacting morbidity and mortality in patients. And not every AI solution are you able to do that with. Like, for example, we talked about the importance of, deep learning for image reconstruction, a very important AI tool, but how are you going to, just because there's improved image quality, does that necessarily translate to improved diagnostic accuracy? I would think it probably would, because if you have improved image quality, you might be able to see those early metastases when they're 1 millimeter in size as opposed to 2 millimeters in size. But it's very hard to prove such things through clinical validation trials such that we can get CMS to reimburse. I know that, like in quantitative volumetrics, it's, we have to bill under the 3D code. Well, that 3D code is not specifically for quantitative volumetrics. And so it leaves a little bit of a gray area. And then what ends up happening is that sometimes it's reimbursed and other times it's not. So we've had to do a close financial audit within RadNet to make sure that the ROI is still positive for quantitative volumetrics. We have found that it is positive, but it's not positive by a large amount, unlike deep learning with image reconstruction, where we're probably at 8 to 15-fold, ROI. And then again, I'd love to hear your comments about the ROI with Viz, because I would think that would definitely be very positive. But I do think that it varies depending on what AI tool you're talking about.
Andy, yeah.
So I think there's two things to consider with this. First of all, the hospital system has changed since 2019, and the pandemic, like everything else, has accelerated the lower acuity services out of the building. Total hips, total knees, those low acuity general surgery cases have left the building. They always used to say, Elvis has left the building, those low acuity cases have left the building. So what does a hospital do? The old accounting measurement is price times volume equals revenue. The services are paying for the AI. The higher acuity services, which hospitals are going to become even more and more high acuity service providers, are using Viz to get better decision making, faster for better detection, and communicate with the team. The DRG in the United States, which is used to pay for Medicare, and the private payers also use that for an intervention, is the revenue that the hospital gets. The AI tool that Viz provides is within that. It's a decision support tool that our physicians and nurses have come to depend on. So I'm not looking for another reimbursement vehicle through CMS. I'm looking at how do we support in a low staffing model, your first question of the conference today, tight physician staffing, tight nursing staffing. They just want to know, what do I need to do now? How do we communicate that? How do we move high volume, high acuity services through the ED faster, to the surgery faster, to the discharge area faster, through the ICU and the step down faster? And Viz supports that communication. And the final thing is the referring docs, the primary care docs, which there's also a shortage of, they want to know what's going on. They want to know that my patient was in the ED. They may not know that. And so the Viz communication tool can loop them in as well. So it's the whole team working together to create high acuity services with the appropriate reimbursement to expand access to care and close the loop.
I think that's a great point. And I think that's one thing that sometimes can be missed. You know, the AI is paid for within a system that is already existing today, right? We got a new technology add-on payment. It was $1,000+. It was nice. But the real ROI for the hospital systems that we work with are the fact they're getting more patient throughput, better utilization of resources, better patient outcomes, and therefore lower length of stay. Plus things like, you know, happier physicians who, you know, will want to stay in the hospital system and do things like research, etc. I don't know if any of you can speak more specifically to the ROI that you've seen at your institution so far.
Well, the qualitative ROI is that the solution works out of the box, and that the nurses, the stroke coordinators, the pulmonary embolism coordinators, the physicians that are involved with the diagnosis and treatment, they are happier. Quantitatively, it allows us to expand and provide that service to a greater network. So we look forward to being able to provide the pulmonary embolism solution that Viz has to our regional network of 70+ hospitals. And then HCA also has 125 hospitals, I believe, using Viz. So also with the rural point that I mentioned earlier, this is not to take care that's inappropriate out of a rural environment or a lower acuity environment and put them into a more expensive, higher acuity environment. The tool is to help with algorithms, give the care team the best decisions to say, we can leave that patient there. They do not need to come to the hospital. And if they do come to the hospital, then the care team's already engaged and they can go much quicker through the care process. If you think about what Viz is automated, and I'll let the doctors talk to all this, compared to where we were 10 years ago with the workflow of using a telephone and then calling the radiologist and getting the read and then calling the ED and then calling the neurosurgeon, the productivity improvement has been substantial. And finally, in economics, when you improve productivity, you improve profitability. And so this tool is qualitatively provides the value. There's also quality metrics, as you've discussed and the physicians have discussed. And then there's an appropriate access to care expansion that can occur when you play. AI is a scale tool. And so the more AI you can deploy, the better diagnostics and better referrals, if they're needed, that you can achieve.
Fantastic. Thank you. So, Dr. Kellner, you work with the life science industry on trials. How should device companies and pharmaceutical companies think about leveraging AI, both in their trials, but also post the trial for getting access to these devices?
There we go. I think the argument for the increased enrollment is a really strong one. A clinical trial cost is essentially the length of the trial, how long it takes you to get the number of patients you need to get for the trial. So if you can decrease that, that's really very valuable to the device or drug company running that study. But you also have the opportunity to improve your population understanding. You're getting the denominator for everybody showing up who's potentially eligible for that, rather than a select group based on who the physicians you're working with happen to engage within the healthcare system. So, for example, for our subdural hematoma trial, I know every single subdural that occurs in our healthcare system, whereas before I was only aware of about 40% of them. And I was very diligent about communicating with everybody and looking at all the scans I can think of and hear about. It was surprising to me how many were kind of slipping through the cracks. So you learn about the actual population you're studying, which is patients presenting to your healthcare system with subdural hematomas. And so maybe you're getting a better understanding of how well your treatment is working by eliminating the bias, the selection bias that might otherwise occur. So I think the value proposition to me is very clear, that there's a clear calculatable dollar amount for increasing your enrollment rate. And then there's the scientific value for better selecting, knowing the denominator for the patients you want to enroll.
Fantastic. And there was a question from the audience about I understand the Viz AI as a communication feature for texting. Have you seen an increase in interdisciplinary teams and communication of patient-needed treatment? And I think the answer to that is, you've all given it, and the answer is yes. One thing that I would add is, we've seen a tremendous improvement in the post-acute stroke coordination between neurologists and cardiologists for cryptogenic stroke. And I asked the question about life science. One thing that life science wants to do is get their drugs and devices that really work well on these patients to the patients that need them. And the only way that happens if the patient is in front of the right clinician, has the right information. We're coming to the end of the webinar, and I just want to thank you all for joining us here today. What I've heard actually reflects something that was said to me earlier today by a CEO of a very well-known health system. I promise I wouldn't say his name. But he said, really, the holy grail is improve quality of care for the patient, improve work lifestyle for clinicians, increase revenue and save costs. And I feel like we've touched on the value of AI in the leading health systems that you all work in today. And I agree with what you all said. AI is here. It's becoming standard of care, and in certain diseases, it's already standard of care. I want to thank you all for joining and providing a phenomenal discussion, even better than I hoped today. And thank you, audience, for joining and the very thoughtful questions. We appreciate your time today, and we hope to see you again soon.